So let us begin with telehealth and the telemedicine. I got many requests about this particular session, so I have decided to explain in detail. So the telemedicine has become significantly more relevant in the recent years due to the combination of the technological advancement, changing patient expectation, and most notably the COVID-19 pandemic, which accelerated its adoption. Now what happened is this telemedicine codes have seen lot of changes over the years. Like from 2023 to 2025, it has undergone the major changes. So as a coder, we must get accustomed to the latest codes and the latest guideline. So let us see what are those latest codes. So let us understand what are the telehealth services. Basically, they include the evaluation and management services conducted without face-to-face visit via electronic communication. So basically, typically telephone by a physician or other qualified healthcare professional. Now, the term telemedicine and telehealth are often used interchangeably across the US healthcare system. The specific codes and the modifiers required these services can differ depending upon the pair. So, so far there is a lot of confusion because Medicare accept few codes, they don't accept few codes, and that's why it's still, processing all this information. So let us understand in details about what are these codes, why were these codes added, who can report these codes, and what are the general guidelines for this code, and how do you select the audio video codes or even the audio codes. So let's go into the detail of this. So we saw that this is the electronic communication. Now this electronic communication is further divided into the synchronous and the asynchronous. What is synchronous? Synchronous involve the real-time communication between the healthcare provider and the patient, typically through the live video or the audio. While the asynchronous telehealth, often referred to as a store and forward, allows patients to send their health information such as through a secure portal, which the provider review and respond to at a later time. So that's the basic difference between a synchronous and asynchronous. So maybe the email or asking the question over the portal, which but the email and the questioning that is stored and forward, and the doctor will not immediately answer. While in this synchronous, the doctor is sitting in front of you, may not be in the direct face to face, but through the video or through the audio, and he is directly talking to you. Now, what types of interaction are used in telehealth? One is video visit, that is a real time conducted via audio visual platform. Then the telephone, that is a ENM consultation provided over the phone. Now the first two are the synchronous telehealth, while the online digital ENM, where the patient initiated a communication via secure practice portal, which is reviewed by the provider later, or the virtual check-in, that is a brief interaction between the patient and the provider through secure messaging or the email. So the next, these two are the asynchronous, while these two are the synchronous. So till 2024, we were using the different code, but in 2025, 17 brand new code for the telemedicine were added. So starting January 1, CPT, the codes 99441 to 9 through 99443 have been officially deleted and are no longer in use. So we have the now new code, and those new codes are 98000 to 007, they are for the audio video, and 98008 to 98015, they are for audio only. And both these codes have the patient status, new patient, established patient. Now there is one more code 98016. It is used for the brief synchronous communication such as virtual checking, and it is the established patient only. And this code is important. Why this code is important, that I will let you know soon. So we have seen the synchronous telemedicine, and in that we have audio video services and only audio services. So in the audio video services, the code range is 98,000 to 98,007, and in that we have two categories, the new patient as well as the established patient. And if you look at the code, you will see that every code has a medical decision making and then the time limit, and similarly even for the established also. And if the time is more or exceeded, then we do use the prolonged service code, and for that we use the code 99417. And same goes for the established, but here the time is 55 minutes and here it is 75 minutes. Then only we start adding the prolonged service time. Now, this is also the code for the synchronous, but they only include the audio. That means the phone call. While the audio video means actually, let's say the FaceTime or the Zoom, where you can see the patient and you can talk to the patient. But this is, we are talking only about the audio. Level of the service based on the MDM or total time, but also must include more than 10 minutes of medical discussion. And we have the code 98008 to 980011, and these are the code for the established patient. So here also you will have the four different level of the medical decision making along with the time, and even for the established patient you will have the four level of the medical decision making along with the time. So what we saw so far is the synchronous code, one for the audio video and second is only for the audio. Now let us understand who can report this code. So if you see the list of the people who can bill for this tele services, they are mainly the doctors, nurse practitioner, physician assistant, certified nurse, midwife, clinical nurse, specialist, or the CRNA or registered dietitian or qualified nutritional professional. So they are the one who can report these codes. Now let us understand a guideline for the non-physician. The non-physician provider like a speech therapist can't use the ENM codes, the telemedicine code. Instead, they should use the code 98966 and 98968 for the telephone services. And let us find out what are the guidelines for the follow-up visit. A follow-up visit may be needed if the patient has a complication or needs a rechecking after the previous visit, and that previous visit could be in person or the telemedicine. Then what are the guidelines? So if the original and a follow-up visit happen on the different days, bill for both. And then there is no specific time gap that is required in between the two visits. And the follow-up can be requested by the doctor, other healthcare provider, the patient or their caregiver. So this is when both the visit happen on the two different days. But if it happens on the same day, we can bill only for the follow-up, not for both. So remember that. Now, when not to use the audio video visit codes. So don't use this code for the routine follow-up calls like sharing the lab result, because there we are not, there is no evaluation and management that is happening. I'm just sharing the lab reports. Then don't use for the asynchronous services like the email and messages, because what we are looking for the synchronous codes. Instead, we have to use the code 99421 to 994 439 online digital ENM code for online messages. Don't use for the services oversight by the clinical staff like the chronic care management. So in this instances, or in this three scenario, we cannot use the synchronous telemedicine code. Now, if you see the audio, video or audio only codes, they are based on the time and medical decision making. Audio only visit must include 10 minutes of medical decision making. Don't count the time spent on setting up the call, booking the appointment, and don't count the time if it is under 5 minutes. time already used for the chronic services like 99437 and 99491, then we cannot use the this code, that is the telemedicine code. And time already used for the principal care management, then also we can't use this particular audio or audio video codes. Now, for the synchronous telemedicine code, we also use the prolonged service. And the code we use it 99417. Now, there is a specific criteria that we apply whenever we are using the prolonged service. First criteria is the primary code is selected based on the time, not the medical decision making. So the primary code is the first code because this will be my second code because you can see the add-on code. So the primary code that I will select, it's also by time, not by the medical decision making. The reported code represent the highest level within its category. So that will be the highest code within that category. And the service extended at least 15 minutes beyond the total time listed for the primary code. And if you see, these are the appropriate primary code if I have to list the prolonged service. And these are the highest level within that category. Like if I'm looking for the audio video, the new patient higher new for the new patient, the highest level is 98003. So just check all the code and they represent the highest level in that category. Now, this is not the regular scenario, but many a time you must have also experienced that whenever the audio video or the audio call is going on, sometimes there is an interruption in the connection. So in that case, how do I code it? So if during the encounter the audio video connection is lost and only the audio communication is restored, report the service based on the mode that constitute the majority of the encounter, audio only or audio video. If audio only is reported, documentation must reflect the requirement for the audio only service. And there must be more than 10 minutes of either medical decision or patient observation. So this is one of its kind of scenario, but I mean, it can happen. And when it happens, we have a guideline for that. Now we have seen different guidelines. So let us put our guidelines into testing. Now the provider had a telephone encounter with its established patient. The encounter included 12 minutes of medical discussion and a total of 20 minutes for the encounter. The MDM documents as straightforward. What is your answer? Now let us collect our data. What is this? This is the synchronize or synchronous telemedicine because it happens over the telephone. Now, what is the status of the patient? The status of the patient is an established patient. Can this be coded? Because yes, we have the guideline that it should at least meet the requirement of the 10 minutes of medical decision. And here it is a 12 minutes of medical discussion that has happened and total of 20 minutes of for the encounter. The MDM was documented at a straightforward. Now in this case, what is happening is we have got the MDM, that is a straightforward, and the time is also given. Now we will check both the things. So as far as the MDS is concerned, we will pick up the code 98012. But if you see the time, we will pick up the code 98013 and we always code the highest level. So here the answer will be 98013, not 98012. So let us take one example to understand the concept of prolonged service. Mr. Smith, new patient, called his doctor and had an audio-video encounter between him and Dr. Robert. Mr. Smith spoke in length about his management and medical decision. The encounter lasted 75 minutes. How will I code it? Now in this case 75 minutes, what is, let us collect our data. So the data collection, it is basically the status of the patient is a new patient. What is the kind of meeting? It is a synchronous meeting, but in that also this is the audio video encounter. And it lasted for how many? It lasted for the 75 minutes. So whenever we are coding for the prolonged service time, we will pick up the highest level code from that category, that is 99003, and that goes on for the 60 minutes. This is a time limit for this code, and ours is 75 minutes, that is a 15 minutes more. So definitely it fulfills the criteria for the guideline, and that's why we will write the code 98003, which is a primary code, and this is a add-on code. So let us take one more example. Dr. Jade had an audio-video encounter with her established patient Tina. The encounter included 12 minutes of medical discussion and total of 20 minutes of the medical decision making. The MDM was documented as straightforward. However, 5 minutes into the encounter, the video connection was lost, and the final 15 minutes was audio only. So now, how will you code this? So we have a guideline that if there is a connection lost, and if the majority of the after that, once they establish the connection, if the majority of the connection is audio or audio video, that will decide the code. Now in this case, what is the majority of the connection? They restored, final connection was 15 minutes of audio. Now what was the total time? The total time was 20 minutes. Out of that, 15 minutes was audio only. So we will code only for the audio connection. Now we have the data. What is the data? It is a established patient, okay, and then the straightforward medical decision making, then it is 20 minutes of total time, and however 5 minutes into, so we, and 15 minutes was audio only. So we have enough data, and now we will zero down our code. So if we have seen this particular example, what happened is, because of the loss of the signal, the later when they established the connection, it was majority of the audio only, because it happened for 15 minutes and the overall meeting lasted for 20 minutes. So in this case, we will be coding for the audio code only, and that is for the established patient, and for which we have the code range 98012 to 98015, and 98013 is for the 20 minutes, so I'll be using that code. Now there is a lot of confusion with this new telemedicine code, because the CMS chose not to adopt 16 of the newly introduced codes for the audio-based and video-based telehealth visits, and continue to use the existing NM code set for search services, except they do recognize the code 98016. Medicare will not provide reimbursement for the remaining 16 codes which are created in the telemedicine. That is the codes from 98000 till 98015. Instead, healthcare providers are required to continue to use the traditional ENM code, that is 99202 to 99215, and pairing them with the correct modifier. So the modifier that we use is 93 for the audio only service, and modifier 95 for the audio visual service. Code 98016 replaces the HECPEX code G2012 for the brief technology-based communication services. Medicare will reimburse 98016 under the following condition. It occurs between the provider and the established patient. New patient is not, we cannot use the code for the new patient. The communication may or may not be audio only. The purpose is to determine whether the more extensive visit, that is an office or outpatient ENM service, is necessary. The interaction must include medical discussion lasting at least 5 to 10 minutes. Now, when we cannot use the code 98016, the provider has seen the patient within the 7 days before this check-in, and a future visit is scheduled within 24 hours or for the sooner available slot after the check-in. So in this scenario, we cannot use 98016. Suppose if the patient is seen for another E&M service on the same calendar day and the time is used to select the level of that other service, and in such cases add the 5 to 10 minutes from the virtual check-in into the total time of the another encounter. Now, in this case, so suppose the patient had E&M service on today's day, and that E&M service was the office visit of the established patient with a moderate medical decision making. And let's assume that it lasted for 38 minutes. And the same day, the patient called a doctor and he spoke on the phone with the doctor regarding whatever his problem, maybe he wanted to discuss and everything. And so, and that meeting, let's say, lasted for 8 minutes. So when I'm coding, I will be adding that 8 minutes of this virtual meeting into the total time. So 38 minutes plus 8 minutes will be 46 minutes. So I'll be coding for the 46 minutes. So let us take this example. Mr. Bob, established patient, called Dr. Jack to discuss his visit 10 days ago. The pain he had been experiencing was worsening. Dr. Jack made an appointment for face-to-face visit on the following day. Will you code? And if yes, what will you code? So, but in this case, we will not code. No code is reported because the patient was scheduled for the visit, face-to-face visit within the 24 hours. So this is the chart for the Medicare reimbursement, and we know that we can use the code 98016, brief communication technology based services such as virtual check-in provided to establish patient. The criteria has to be established patient, and this code now replaces this code. Now, if it is a audio video meeting, then we can use the office visit code. Place of service is 2 or 10. This is very, very important. 2 is telehealth provided other than in the patient home, that is in the hospital. And 10 is when it is provided in the patient home. If it is only audio, again the place of service is 2 or 10. We can use the modifier 93, can use the office visit code. It is not for routine use, only in certain situations. The provider must have the video capabilities, but the patient does not or refuses. So this is very, very important chart for the Medicare. And this is here, we finished the telemedicine. Just go through the slides once again.